Hello, my name is Shannon Allen, and I'm a doctoral student at North Central University studying the psychology of trauma and crisis. Today I'm going to discuss ways that you, as counselors, can help military members that have suffered trauma reframe their experiences so they can begin to recover. Today's topics will include some definitions related to trauma, the prevalence of traumatic stress among military members and veterans, physiological, psychological, emotional, and behavioral traumatic stress responses, and an overview and case studies of the trauma reframing techniques, emotional freedom technique, cognitive restructuring, and eye movement desensitization reprocessing therapy. Traumatic stress reflects painful, distressing, intense, and potentially life-threatening experiences that occur beyond the range of ordinary experiences. These experiences can be direct or vicarious. Traumatic stress is more common after certain types of traumatic events like combat and sexual assault. Military members exposed to combat may have to kill or injure others, may see others being killed or injured, and may have been injured themselves, and are usually in a prolonged, heightened state of alert. Added to this, being away from home for extended periods may also aggravate an already stressful situation. Another source of military stress is sexual trauma. Sexual trauma can be repeated exposure to threatening sexual harassment or sexual assault. Certain factors like age, gender, type of trauma, previous traumas, pre-existing mental health issues, and support after the trauma can mitigate or moderate whether an individual will develop a trauma-related psychiatric disorder. For military members specifically, other factors may include the individual's role in combat and the politics of war. According to the Department of Veterans Affairs, between 11% and 20% of military members serving in Operations Iraqi Freedom and Enduring Freedom develop post-traumatic stress disorder in a given year. Around 12% of military members that served in the Gulf War developed PTSD in a given year, and about 15% of Vietnam veterans develop PTSD in a given year, and around 30% in their lifetime. In addition, there are other traumatic experiences unrelated to war that military members may be exposed to. For example, about 23% of women reported having been sexually assaulted while in the military. Approximately 55% of women and 38% of men experience sexual harassment while in the military. When an individual is exposed to a stressful situation, the sympathetic nervous system and the hypothalamic pituitary adrenal axis are activated. These systems release hormones that prepare the body to deal with a threat. Once the threat is no longer present, the parasympathetic nervous system returns balance to the stress response systems. This balance is called homeostasis, and this is a typical and healthy response to stressful situations. However, when stress is prolonged or intense, such as in PTSD and traumatic stress, the stress response systems are persistently activated. When this occurs, there is an overdose of stress hormones, which activates a process called gene methylation. During gene methylation, chemical markers attach to the genes that regulate stress responses. So, as expected, the stress response and the systems that control it become dysregulated and imbalanced. This results in the body being in a constant state of alert. There's a broad range of physiological, psychological, emotional, and behavioral impacts related to the body's inability to return to homeostasis. This can range from mild to debilitating. It's not uncommon for individuals exposed to traumatic stress to present with physical symptoms such as sleep disturbances, sexual problems, cardiovascular, musculoskeletal, gastrointestinal, dermatological, and respiratory issues. However, unresolved traumatic stress has also been linked to many chronic health conditions such as Cushing's syndrome, metabolic syndrome, arthritis, osteoporosis, high cholesterol, hyper and hypothyroidism, lupus, fibromyalgia, muscular sclerosis, heart disease, liver disease, stroke, chronic obstructive pulmonary disease, diabetes, hepatitis, and lung cancer. So, considering these adverse physiological effects, it shouldn't be surprising that exposure to traumatic stress has the potential to significantly truncate the sufferer's lifespan. Psychological and emotional responses to traumatic experiences include hallucinations, memory disturbances, depressed mood, chronic anxiety, persistent feelings of impending doom, anger issues, somatic symptoms like back pain, joint pain, and headaches, and suicide. They also include issues with self-concept, dissociation, future orientation, affect regulation, cognitive problems, and the development of psychiatric conditions. So let's look more closely at the last 6 symptoms. Issues related to self-concept are inconsistent or unpredictable sense of self, guilt, shame, low self-esteem, and distorted body image, especially in female sexual violence victims. Dissociative symptoms may include depersonalization, impaired memory or amnesia, and altered states of consciousness. Future orientation issues may result in feelings of hopelessness and powerlessness, learned helplessness, distrust in the world, decreased social competency, psychological myopia, and negative expectations. These issues can lead to isolation, distrust, and apathy that can negatively impact relationships. Deficiencies in affect regulation can cause difficulty expressing emotions and poor emotional control, and a misunderstanding of internal states. Cognitive problems may manifest as issues with planning, task completion, and attention. And psychiatric disorders associated with traumatic stress include panic disorders, major depressive disorder, obsessive compulsive disorder, generalized anxiety disorder, mood disorders, PTSD, acute stress disorder, adjustment disorder, and disinhibited social engagement disorder. Exposure to traumatic stress can also manifest behaviorally. For example, stress responses can be significantly impacted. For instance, hypervigilant behaviors may present as impulsive, defensive, hostile, and overreactive responses to non-threatening situations. Reversely, hyporesponsiveness to legitimate threats, illness, pain, and body regulation, like eating, elimination, and sleeping, may also occur. Health risk behaviors include drug and alcohol abuse, smoking, poor nutritional choices, decreased physical activity, and promiscuity. And these issues can cause problems within the marriage and family unit as well as work performance. For example, decreased productivity and more frequent absences are typical of those who have experienced a traumatic event. Given how pervasive traumatic stress responses are, the helping professions must understand effective treatment techniques and how to effectively implement them. Most trauma treatments involve reframing. Typically, your client's stress response is activated by perceived stress related to their traumatic experiences. Reframing refers to helping clients alter their perceptions of traumatic events or to make meaning of the event so their body's stress response is not activated in the face of trauma triggers. So next I'm going to go over the reframing techniques, emotional freedom technique, cognitive restructuring, and eye movement desensitization reprocessing therapy. Emotional freedom technique, also called EFT tapping, is a type of psychological acupressure used to balance energy systems. EFT focuses on the flow of energy through meridian points. The theoretical basis for EFT is that distressing thoughts impede the flow of energy. EFT is rooted in exposure and cognitive therapies and works by reframing distressing feelings by pairing them with positive affirmations. Supporters of EFT posit that tapping meridian points while repeating positive affirmations sends signals to the part of the brain that controls stress. EFT is done in 5 steps. First, help the client identify a specific issue. Only one issue should be addressed at a time. Next, on a scale of 0 to 10, the client should rate how intense the issue or feeling is. For example, how much emotional pain or discomfort does the client feel when focusing on the issue? This number will be a baseline by which to measure improvement. Third, help the client establish a positive affirmation. The affirmation should acknowledge the problem, reframe the problem in a new perspective, and end by accepting oneself despite the problem. And they generally include even though statements. For example, even though I was severely injured and almost died in Iraq, it is over, I am home, and I am safe, and I accept myself deeply and completely. Typically, the reframe portion of the affirmation will use language that you suggest because the goal is to trigger a eureka moment when the client recognizes a more adaptive understanding of their trauma experience. Once the affirmation setup is complete, you can then begin directing the tapping sequence. Have the client tap each of the following meridian points 7 times while repeating their affirmation 3 times. Start with the eyebrow, then the side of the eye, under the nose, chin, beginning at the collarbone, under the arm, and finally at the top of the head. The final step is to retest the intensity of the feeling. Have the client repeat the tapping process until their intensity level is 0. Now let's look at some literature pertaining to the effectiveness of EFT. In 2009, Church and colleagues tested the efficacy of 6 EFT sessions on 7 veterans returning from Afghanistan and Iraq who suffered from anxiety, depression, PTSD, and other psychiatric issues. Participants were assessed post-treatment, immediately after treatment, and in a 3-month follow-up. At follow-up, symptom severity decreased by 40%. Anxiety symptoms decreased 46%. Depressive symptoms decreased 49%. and PTSD symptoms decreased by 50%. In another study, Church conducted a pilot EFT examination on veterans returning from Afghanistan and Iraq diagnosed with PTSD. While a sample for this study was small, 11 veterans found that after EFT, the sample no longer tested positive for PTSD. Psychological distress significantly decreased, and these results endured over time. In 2013, Church and colleagues again tested EFT's efficacy on veterans diagnosed with PTSD, but this time they used a randomized control trial. 6-hour-long EFT sessions were given to the experimental group of 30, and 29 were assigned to standard care. Pre-assessment, immediate post-assessment, 3 and 6 month assessments were conducted. The EFT group showed significant decreases in psychological distress. 90% of the EFT group tested negative for PTSD, while only 4% of the control group tested negative. The within-group analysis showed that 60% of the EFT group no longer met the clinical criteria for PTSD after only 3 sessions, and 86% after 6 sessions. This percentage was sustained at both the 3 and 6 month follow-ups. Cognitive restructuring, sometimes referred to as cognitive processing therapy, is built on the premise that some thoughts and emotions about traumatic events tend to be distorted. CR helps trauma victims identify, evaluate, and challenge beliefs about the trauma and move towards more accurate and balanced thoughts. CR helps clients find new ways of thinking about their trauma so they can better cope with triggers. The ultimate goals of CR are to help the client have a better understanding of what traumatic stress is and how it has impacted their lives, feel a greater sense of control over their symptoms, and therefore experience a reduction in their symptoms. CR typically involves 12 to 16 individual sessions and involves 6 steps. Step 1 is to help the client identify the distressing situation or issue. Step 2 involves having the client record their negative feelings in perhaps a thought record. And this is what a thought record may look like. Encourage clients to use specific emotional words like guilty, confused, hopeless, horrified, and angry. It might be helpful also to give the client a feelings list. Then have the client rate the feelings from least intense to most intense on a scale of 1 to 10 on their thought record. Step 3 involves the client recording their automatic thoughts. Remember, automatic thoughts are typically random and spontaneous. These thoughts might seem logical to the client, but are often the sources of negative and distorted perceptions about themselves as they relate to their trauma. Some examples are, it's my fault my unit was attacked. Everyone in my unit hates me and blames me. Once the client records their automatic thoughts, have them rate how much they believe each one to be true on a scale from 0 to 10. Before starting step 4, give your client a checklist of cognitive distortions, or you can just discuss them. A cognitive distortions checklist may look something like this. And I'm not going to read all of these, as I'm sure you're well acquainted with cognitive distortions, but here are a couple just to give you an idea on how you might develop a checklist. Overgeneralization. The client views a negative event as a never-ending pattern of defeat. Should statements. the client criticizes themselves or other people with shoulds or shouldn'ts, musts, oughts, and have tos are similar offenders. Continuing with step 4, have your client analyze their automatic thoughts using the checklist by recording their observations on the thought record. Have the client point out how the thoughts are irrational, unrealistic, or unfair. Then have the client rate the automatic thoughts again. If the ratings have not improved, continue the discussion on cognitive distortions. Step 5 includes reconstructing automatic thoughts in a more realistic, objective, balanced, and adaptive way. This handout can help both you and the client untangle automatic thoughts. For example, examine the evidence. Instead of assuming that your negative thought is true, examine the actual evidence for it. Another one may be the semantic method. Simply substitute language that is less colorful and emotionally loaded. Or you can do a cost-benefit analysis. List the advantages and disadvantages of a feeling. Finally, together with the client, evaluate the restructured thought. Ask the client to rate the believability of the restructured thought on a scale of 0 to 10. Determine if the belief in the reconstructed thought is higher than the automatic thought. Rate the intensity of the feelings again as well. Determine if they are less intense. If not, more work is needed. Now, let's look at some research on CR. Monson and colleagues tested CR's efficacy on 60 veterans with chronic PTSD in a randomized controlled trial. Compared to the control group who received no treatment, 50% of the CR group saw significant improvements in PTSD symptoms and other comorbid disorders in post-treatment assessments. In another randomized controlled trial, Suris and colleagues tested the efficacy of CR on military members who had suffered sexual trauma. 86 veterans were randomly assigned to receive CR or present-centered therapy, or PCT. Pre-treatment, immediate post-treatment, 2, 4, and 6-month assessments were evaluated. Participants who received CR had significantly more reductions in PTSD symptom severity than those who received PCT. In addition, the CR results were maintained at the follow-up to a higher power than PCT follow-ups. The last technique I'm going to discuss is eye movement desensitization reprocessing therapy, or EMDR. EMDR is based on the idea that negative feelings and thoughts result from unprocessed memories. EMDR involves having clients recall traumatic thoughts, emotions, images, and bodily sensations, while simultaneously the therapist uses a form of bilateral stimulation, such as moving an object back and forth, while the client holds their head still and uses only their eyes to follow the movement. While the mechanisms that underlie the efficacy of EMDR are still being investigated, it has been proposed that EMDR degrades the client's working memory, which allows them to view the trauma from a distance, where they can experience, evaluate, and understand the trauma without being inundated with intense negative emotions, because the bilateral stimulation limits the amount of information they can process. Regardless of what makes EMDR effective, it is recognized by the Veterans Administration and the American Psychological Association as an evidence-based practice. Okay, let's go over some EMDR efficacy studies. A 1999 study examined the effectiveness of EMDR compared to exposure therapy, or ET, on 12 Vietnam War veterans with PTSD. Both groups were given only one treatment. Both the EMDR and ET groups showed significant improvements on the impact of event scale. However, the EMDR group showed more significant improvements on the subjective units of discomfort scale and the self-reported severity of intrusive thoughts related to war trauma. Carlson and colleagues used a randomized controlled trial to compare EMDR with biofeedback-assisted relaxation outcomes. 35 combat veterans diagnosed with PTSD were randomly assigned to 12 sessions of EMDR or 12 sessions of biofeedback. Post-treatment analysis found that EMDR was more effective in reducing PTSD symptoms, and the effects were apparent at the 3-month follow-up. A more recent study examined the efficacy of EMDR on active duty military members who had PTSD. 46 members received EMDR, and 285 members received treatment as usual, or TAU. They were monitored for 10 months. Participants who received EMDR had significantly fewer sessions, but with significantly greater gains than the TAU group. Just to quickly summarize what we've discussed today, there's an extensive range of physiological, psychological, emotional, and behavioral impacts of traumatic stress. Traumatic experiences like combat and sexual assault increase the likelihood that an individual will develop PTSD. However, a variety of factors such as personal and environmental factors often determine trauma responses. The most effective treatments involve reframing the traumatic experience. Some evidence-based reframing techniques include emotional freedom technique, cognitive restructuring, and eye movement desensitization reprocessing therapy. All these techniques help clients make meaning of their experiences, so trauma symptoms are less pervasive and they can begin the process of recovery. Thank you so much for allowing me to speak to you today. I hope I've provided you with some valuable information that will help you continue your excellent and critical work with military trauma victims.